Welcome to the deep dive. Today, we're really zoning in on a big one for the MSRA, type 1 diabetes mellitus, or T1DM.
Absolutely essential stuff.
We're using our MSRA revision notes as the backbone here, and the plan is simple. Pull out all the high-yield knowledge you absolutely need.
Yeah, we're going to cover everything from, what it actually is, right through to the complications. We want to make this clear, memorable, and hopefully a bit less daunting for your revision.
Exactly. No overwhelm, just the key facts. So let's start right at the beginning. What, fundamentally, is type 1 diabetes?
Okay, so at its heart, type 1 diabetes is a chronic autoimmune disorder. Basically, your own immune system gets confused.
Confused how?
It starts attacking the insulin-producing beta cells in the pancreas. It sees them as foreign invaders, essentially. And over time, it destroys them.
Oh, okay. So the body attacks itself, wiping out the insulin factory.
Precisely. And this leads to what we call an absolute insulin deficiency. Not just less insulin, but eventually pretty much none produced by the body itself.
And the consequence of having no insulin is?
Well, insulin is the key that lets glucose, sugar, get from your blood into your cells for energy. Without that key, glucose just builds up in the blood.
Right, leading to high blood sugar, hyperglycemia.
Exactly, hyperglycemia, and all sorts of metabolic knock-on effects. The key things to remember are it's autoimmune. You'll often find specific autoantibodies against those beta cells, and it's driven by these immune cells called autoreactive T cells.
And they do a lot of damage.
Oh, yeah. We're talking about the destruction of maybe 80 to 90% of the beta cells before things really become clinically apparent. That level of loss is what causes that absolute need for insulin from outside.
Wow. Okay. And how might this first show up? Especially thinking about kids and younger adults where it's more common. What are the initial signs?
The classic symptoms usually stem directly from that high blood sugar. You'll often see polyuria that's peeing a lot, more frequently than usual because the body's trying to flush out the extra sugar.
Polyuria.
And then polydipsia being really thirsty all the time, partly because of losing so much fluid through urination.
Makes sense.
Often there's unexplained weight loss, even if the person is eating normally or even more than usual, and just general tiredness, fatigue.
Right, the classic polys plus weight loss and fatigue. Definitely things to watch for. So what actually causes this autoimmune attack? What's the etiology?
It's thought to be a mix, really. There's a genetic predisposition yet. Some people's genes just make them more susceptible.
Okay.
And then there seems to need to be an environmental trigger, something that kicks the process off in someone who's already susceptible.
So genes load the gun, environment pulls the trigger.
That's a good way to put it, yeah. The immune system gets mistakenly activated against the beta cells, and then it's this slow, progressive destruction. Sometimes there's even a pre-diabetes phase where the autoimmunity is active, but insulin production hasn't dropped low enough yet.
Interesting. What sort of environmental triggers are we talking about?
Well, things that have been looked at include viral infections. The idea is maybe some viruses look a bit like beta cell components, causing confusion for the immune system.
Like molecular mimicry.
Exactly. Other factors might include certain dietary components early in life, maybe exposure to toxins, even things like significant stress have been suggested, though the evidence varies. Oh, and some studies suggest early stopping of breastfeeding might be linked too.
Okay, so it's complex. Genes and environment interacting. That brings us nicely to risk factors. Who's most likely to get T1DM?
The biggest single risk factor is definitely family history. Having a parent or sibling with type 1 significantly increases your risk.
Right.
And then those genetic factors we mentioned, specifically certain HLA genes are strongly associated. You definitely need to know HLA-DR3 and HLA-DR4 for your MSRA. They really increase susceptibility.
HLA-DR3, HLA-DR4. Got it. What else?
Those environmental triggers, again, viral infections, maybe enteroviruses are particularly implicated, possibly early diet factors, as I mentioned. Age is a factor, too. It peaks in childhood and adolescence, around puberty often.
2 peaks, I think. Like 4, 6, and 10, 14 years old.
That's right. Those are the main peaks, although it can absolutely occur at any age, even well into adulthood. And a really important link is with other autoimmune conditions.
Ah, yes. You mentioned the immune system going awry.
Exactly. If you already have an autoimmune disease like Hashimoto's thyroiditis, or maybe type A gastritis, celiac disease, even primary adrenal insufficiency, your risk of developing T1DM is higher. It's like the immune system is already primed to attack self.
That makes a lot of sense, that connection. Okay, let's get into the nuts and bolts, the pathophysiology. What's actually happening inside the body?
So the core problem, as we've said, is that immune attack destroying the beta cells. No beta cells means no insulin. absolute deficiency.
No insulin means.
Glucose can't get into the cells to be used for fuel, so it piles up in the bloodstream, hyperglycemia. The cells are basically starving, even though there's plenty of sugar around.
Like having a key, but it doesn't fit the lock.
Pretty much. So the body, desperate for energy, starts breaking down fat instead.
Okay. An alternative fuel source.
Yes, but breaking down fat produces byproducts called ketones. A few ketones are okay, but when the body relies heavily on fat burning because there's no insulin effect, ketone levels can rise dramatically.
And that's bad.
That's very bad. High levels of ketones make the blood acidic, leading to diabetic ketoacidosis, or DKA. It's a medical emergency. And don't forget the inflammation aspect, too. The immune attack itself causes inflammation in the pancreas, releasing damaging chemicals, cytokines that help destroy those beta cells.
DKA. Definitely need to remember that. We'll circle back to complications. But first, if someone presents with high blood sugar, what else could it be? What are the main differential diagnoses?
Good question. Number one differential is usually type 2 diabetes. Very different cause, different management, so crucial to distinguish.
Okay.
Then there's LEDA, latent autoimmune diabetes in adults. It's like a slower burning form of T1DM, often mistaken for type 2 initially because it comes on more gradually in adults.
LEDA.
Right. And you always have to consider secondary causes, maybe diabetes caused by pancreatic disease like chronic pancreatitis or certain medications like high-dose steroids.
Got it. Good to keep those in mind. How common is T1DM overall? What's the epidemiology look like?
It accounts for about 5 to 10% of all diabetes cases, so much less common than type 2.
Right.
As we said, typically diagnosed in children and young adults peaking around puberty. In the UK, the incidence is estimated at around 25 new cases per 100,000 people each year.
And those peak ages, again, were 4, 6, and 10, 14.
Yep, those are the main ones. But always remember, while it's most common before age 20, you can diagnose T1DM at any age.
Okay, so let's paint a picture of the clinical features. What does someone with new-onset T1DM typically look like or complain of?
It really comes back to that hyperglycemia. So think the polys again, polydipsia, excessive thirst, polyuria, frequent urination, maybe bedwetting in a previously dry child.
Right, the polymany idea helps. Dipsia, thirst, urea, urine.
Exactly. Then polyphagia, extreme hunger, despite the weight loss that often happens. Phagia, eating.
So thirsty, peeing loads, hungry, but losing weight.
That's the classic quartet, often accompanied by profound fatigue or tiredness. Blurred vision is common too because high glucose affects the eye lens. And because diabetes can affect immune function and healing, you might see slow healing wounds or recurrent infections like UTIs or thrush.
Okay, those are the more gradual onset signs. What about that emergency scenario, DKA? What are the red flags for that?
DKA is a much more acute picture. You'll often see significant abdominal pain, sometimes mimicking an acute abdomen. The polyuria and polydipsia are usually still there, leading to quite marked dehydration.
Right.
A key respiratory sign is Kussmaul breathing, this deep, rapid, sighing respiration as the body tries to blow off the excess acid, carbon dioxide.
Kussmaul breathing. Got it.
And the classic one is the smell of acetone or pear drops on the breath. It's due to the high ketone levels, plus depending on severity, you can get altered mental status, confusion, drowsiness, even coma.
That pear drop breath is a big clue for exams. Okay, so someone comes in looking like this, or with the classic poly symptoms. How do we confirm it's T1DM? What investigations do we do?
First step is often a urine dipstick. You're looking for glucose, obviously, but critically, ketones. Ketones in the urine plus high blood sugar strongly points towards T1DM, especially DKA.
Urine dip, glucose and ketones. Then bloods.
Yes, blood glucose measurement is key. Diagnostic criteria usually involve a fasting glucose of 7.0 millimole or more, or a random glucose of 11.1 millimole or more. An oral glucose tolerance test isn't usually needed if symptoms are clear and glucose is high.
What about HbA1c, the long-term sugar measure?
It's vital for monitoring established diabetes, but for initial diagnosis of T1DM, maybe less helpful if the glucose has shot up really quickly, which it often does. The HbA1c might not have had time to rise significantly yet.
Okay, so what tests really help differentiate T1DM?
C-peptide levels are crucial. C-peptide is made alongside insulin when the pancreas produces it. So in T1DM, where the beta cells are destroyed, C-peptide levels will be very low or undetectable. That signifies that insulin deficiency.
Low C-peptide equals low insulin production. Makes sense. And the autoantibodies.
Yes. Testing for diabetes-specific autoantibodies is really important to confirm the autoimmune nature. We look for anti-GAD antibodies. They're positive in about 80%. Islet cell antibodies, ICI positive in 70–80%. Insulin autoantibodies, IAA, more common in younger kids, and IA2A antibodies as well.
So finding one or more of those really supports a T1DM diagnosis.
Absolutely. It helps distinguish it clearly from type 2, where these are typically absent.
So to summarize diagnosis, symptoms plus high glucose, one reading might be enough.
Is symptomatic? Yes. Usually one high reading, fasting 7.0, random 11.1, is enough, especially if ketones are present. If the person is asymptomatic, say picked up on screening, you generally need 2 separate high readings.
In adults, certain features might make you suspect T1DM more.
Definitely. Things like ketosis at presentation, rapid weight loss, being younger than 50, having a lower BMI, say under 25, and a personal or family history of other autoimmune diseases, those all point more towards T1DM, even in an adult. If the picture is less clear, maybe older onset, higher BMI, slower symptoms, then C-peptide and antibody tests become even more vital to differentiate from T2DM or LADO.
Right, putting all the pieces together. Okay, diagnosis confirmed. What's the management strategy for T1DM?
Management is lifelong and revolves around insulin replacement. Since the body doesn't make it, you have to provide it.
Oh,
Usually either through multiple daily injections, typically a combination of long-acting basal insulin and rapid-acting bolus insulin before meals, or via an insulin pump, which gives a continuous subcutaneous infusion.
okay, insulin is fundamental. What else?
Monitoring blood glucose is absolutely essential. Traditionally, this was self-monitoring with finger prick tests, SMBG, but increasingly, continuous glucose monitoring, CGM, is used. NICE actually recommends offering CGM either real-time or intermittently scanned to all adults with T1DM now.
CGM is becoming standard then. What about lifestyle? Diet, exercise?
Hugely important. While they don't replace insulin, they are critical for good control and overall health. Detailed dietary education from a dietitian is key, tailored to the individual. Regular physical activity helps with insulin sensitivity. Smoking cessation support is vital.
Anything else practical?
Yes, things like wearing medical ID, informing the DVLA about the diagnosis for driving regulations, and knowing how to manage insulin and supplies when traveling are all part of the package.
Okay, going back to insulin regimens, you mentioned basal bolus.
Yes, that's generally the recommended approach, as it mimics the body's natural insulin pattern most closely. A background, basal insulin level, topped up with mealtime bolus insulin. But the specific insulin types and doses are highly individualized.
And blood glucose checks. How often?
If using SMBG, typically before each meal, before bed, and sometimes after meals or before exercise. Targets are also individualized, working with the diabetes team.
And there's a big focus on annual reviews, right?
Absolutely crucial. A yearly checkup with the whole multidisciplinary team, doctor, nurse, dietitian, podiatrist for foot checks, optometrist for eye screening. The focus is on assessing control, adjusting treatment, and screening for and managing long-term complications early. Things like checking kidney function, blood pressure, cholesterol, looking at injection sites. Regular dental checks are important too.
What about kids and young people specifically?
Similar principles, but also need close monitoring for growth and development, managing insulin needs through puberty, plus regular screening for associated conditions like thyroid disease, celiac disease, as well as the standard checks for retinopathy, nephropathy, and hypertension. Insulin doses often need frequent tweaks for activity, illness, growth spurts.
Any other medications sometimes used? Metformin, maybe?
Metformin might be considered alongside insulin if someone with T1DM also has significant insulin resistance, typically indicated by a higher BMI, say over 25. But it's not standard T1DM therapy otherwise.
And general diet advice. Low carb.
Not necessarily strict low carb, but generally a balanced, healthy diet. Emphasizing low glycemic index foods, high fiber, reducing saturated fats and sugars, moderate protein. Consistency is often key.
What about alcohol?
Need to be careful. Alcohol can increase the risk of hypoglycemia, sometimes delayed. Best consumed with carbs, avoid binge drinking, and monitor glucose closely.
So it's a really comprehensive, ongoing management plan. Very individualized.
It has to be. Keeping a good diary of glucose readings, food, activity helps enormously. Regular checkups, screening for complications, psychosocial support, vaccinations like the pneumococcal jab. It's all part of maintaining health long term.
Which brings us to prognosis. What's the outlook these days for someone with T1DM?
Well, it's still a chronic condition, no cure as yet, but the outlook is vastly better than it used to be. With good management, keeping glucose, blood pressure, and lipids controlled, people can live long, healthy, active lives.
But poor control still leads to problems.
Yes, definitely. Poor long-term control significantly increases the risk of those serious complications we've touched on. Heart disease, stroke, kidney failure, blindness, nerve damage, foot amputations.
So the potential downsides are still significant.
They are, but the tools we have now have better insulins, pumps, CGM, better understanding of diet and exercise, comprehensive screening mean that achieving good control and preventing or delaying complications is much more achievable. Adherence to treatment and lifestyle is key. Early detection and management of any emerging complications makes a big difference too.
That's definitely more positive. Okay, let's just clearly list those complications again, both acute and chronic.
Sure. Acute complications, the immediate dangers, are primarily diabetic ketoacidosis, DKA, that state of high glucose, ketones, and acidosis, and hypoglycemia, or hypo's low blood sugar, usually from too much insulin relative to food or activity.
DKA and hypos.
Got it.
And chronic.
Chronic complications develop over years, usually due to prolonged high blood sugar damaging blood vessels and nerves.
Right.
So, cardiovascular disease is a major one, increased risk of angina, heart attacks, strokes, peripheral arterial disease.
Okay.
Then diabetic nephropathy, kidney damage, potentially leading to kidney failure and needing dialysis or transplant. Diabetic retinopathy, eye damage affecting the retina, can cause blindness if untreated.
Eyes and kidneys, common targets.
Very common. Also, diabetic neuropathy, nerve damage. This can cause pain, numbness, tingling, usually in feet and hands first, but also affect autonomic nerves controlling things like digestion, heart rate, bladder function.
Right.
And diabetic foot complications are a result of neuropathy, loss of sensation, and poor circulation, peripheral arterial disease, leading to ulcers, infections, and potentially amputation. Plus, generally increased susceptibility to infections and things like periodontitis, gum disease.
A sobering list really underlines why good control is so vital. Okay, I think that covers the core information really well. We've gone through the definition, causes, risks, pathophysiology, differentials, epidemiology, the clinical picture, investigations, a pretty detailed look at management, prognosis, and those crucial complications.
Yeah, hopefully that's a solid overview for anyone hitting the books for the MSRA. Remembering the autoimmune basis, the absolute insulin need, those classic symptoms, the importance of insulin therapy and monitoring, and being aware of DKA and the long-term risks, those are the real headlines.
Definitely. So as you're processing all this, here's something to chew on for your revision, especially for those trickier MSRA questions. When you have an adult presenting with new diabetes, maybe with some features that aren't textbook T1DM or T2DM, what are the subtle clues in their history, presentation, and initial blood tests that can really help you tease apart whether it's more likely T1DM, LADA, or maybe early type 2? Thinking about those nuances is key.
Good question. And of course, for much more detailed revision notes, loads of practice questions, mock exams, and everything else you need to really get ready for the MSRA, head over to passmsra.com.
And don't forget, there are also excellent free resources, quizzes, and learning materials available at freemsra.com. Well, thanks for joining us on this deep dive into type 1 diabetes. We really hope it helps clarify things for your MSRA prep.